A very common scenario. I won't labour this, Eugenie has already talked about this, and I just really want to make the point in the next few minutes that with the vocal fold injection techniques that we're using, it's no longer reasonable to watch and wait when you see a patient with a vocal fold paralysis. You heard a story about a patient who waited 20 months even to get into the voice clinic. That I think is unacceptable, and I think these days we would be able to treat somebody like that within just a few weeks. This is my sort of noddy way of thinking about how I manage the vocal fold paralysis pathway. You'll see that actually, whatever the cause of the vocal fold paralysis, whether you think it's going to be permanent or temporary, all of these patients are going to have an injection under local anaesthetic if they will tolerate it. I think it's an extremely reasonable way to go about things pretty rapidly. Historically, what would we have done? Well, we'd have watched and waited. Patients would have had voice therapy, and you might have waited 12, 18 months. And in that time, patients may not have been able to work adequately, social interaction would have been limited, and at the end of that time you might have offered them an injection under general anaesthetic or a thyroplasty. But again, I think injecting patients early, if at all possible under local anaesthetic, is absolutely the way forward. Why under local anaesthetic? Well, if you ask the patients, they prefer it. Clearly it obviates the need for a general anaesthetic, and you can see and treat patients very rapidly. Think about the palliative patients who need a very rapid improvement, perhaps just to give them some voice and improved swallow for the last few weeks of their life. It also means, I think, that as you're injecting under local anaesthetic, you can assess the amount of material you need to inject, and you're assessing the degree of filling required in order to get adequate closure. If you're doing it under general anaesthetic in a static field, you really have no idea how much material you need to be injecting. Injecting under local anaesthetic in the UK, there are two primary products available. Renu Voice. If you're running into problems with a shortage of Renu Voice, then come and have a chat with me afterwards, because there are potential alternatives. And Restylane hyaluronic acid. Hyaluronic acid typically lasts a few months, whereas Renu Voice lasts very much longer, and you can use either of those depending on the scenario and whether you think you're going to need a short-term or a relatively long-term fix. There are other injection materials available. Fascia, fat and bioplastic obviously need to be injected under general anaesthetic. I haven't used Vox bioplastic for a number of years. Again, it can cause quite significant problems in my experience, and there are some other materials that I haven't used for a long time. So if you're going to do local anaesthetic injections, and I would encourage you, if you're not doing them, actually to think about getting trained in doing it and getting your voice therapy colleagues on board with it as well. It's relatively straightforward, and I'm going to be running training for anybody who's interested in learning some hands-on skills, so do let me know. It's very straightforward. You need a chip-tip stack system, you need some local anaesthetic, some material you're going to inject, and a competent assistant, and in my clinic the competent assistant is my voice therapy colleague. I do all of my vocal fold injection augmentations percutaneously. You can do them orally with a bent needle over the back of the tongue, and some of our European and American colleagues do that. I never have. The percutaneous techniques by and large work fine for me. So through the thyrohyoid membrane, having squirted some local anaesthetic in the nose, I inject some local anaesthetic into the skin, and then through the skin and into the airway, inject some 2% lignocaine into the airway. That makes the patient cough, and I'm looking at the screen as I'm doing this, obviously, and that washes the local anaesthetic up and down. And then the patient, and then you guide the needle through the thyrohyoid membrane. The needle appears in the supraglottis, and I'm sort of orientating myself here, sort of dab on the vocal fold just to be sure I'm in the right place, aiming into the thyroarytenoid muscle as you would normally under general anaesthetic, and then inject the filler material. Sometimes the patients will say that there's a bit of earache at this stage, it might hurt a little. The degree of pain in these scenarios is actually very variable, I find. Some patients have absolutely no problem with it at all, some patients find it more uncomfortable, but it is very, very unusual for a patient not to be able to tolerate this being done under local anaesthetic. And you'll see that I'm aiming to slightly over-inject here. That's the aim of the game, is actually to slightly over-inject, because the carrier material in the calcium hydroxylapatite is going to dissipate over time. Through the cricothyroid membrane is the other way of doing it, coming from underneath the vocal fold. This is my less preferred way of doing it, because at the point when the needle goes into the vocal fold, you lose sight of it, and you have to sort of use the force a little bit, and you feel a little kind of pop as it goes in, and then you know you're in the right place. But I find this a little bit less satisfactory, and that's the right vocal fold filling up there. Let's just move on. So further treatment, if the injection wears off, well, you can repeat it if you like. I mean, there comes a point where you inject once, you inject twice, and you think, well, we probably should do something a bit more permanent now. And in my hands, that would be a thyroplasty, but we're going to hear about thyroplasty and about re-innovation in just a minute. Just briefly to say, there is evidence, good evidence now, that injecting early after the onset of a vocal fold paralysis gives better long-term outcomes. If you inject within a few months of the onset of a vocal fold paralysis, you are much less likely subsequently to need to go on to perform a thyroplasty. So again, it's just that thing about seeing the patient early, treating the patient early, and then you're much less likely to need to do something further down the line. There are a couple of studies looking at that, and the American endocrine surgeons are sort of onto this as well. They realise that they need to be referring patients early if they've pranged a nerve in the course of doing a thyroidectomy. Can you do injections for big glottic gaps? Yes, you can. You'd think that they wouldn't work quite so well, and you'd be right. But it is possible. You know, in this scenario, clearly this chap's got an enormous glottic gap and is aphonic. And I didn't hold that much hope that I was going to be able to get very much material into that paralysed left vocal fold. I was aiming very far laterally to get into it. So here comes the needle. And the bottom line is that it is possible to do injections for big glottic gaps. They're more technically challenging, and B, they're more likely to wear off reasonably quickly. But let's just watch this material going in. Part of the issue here is that getting the needle lateral enough to get into the thyroarytenoid muscle is actually a bit of a struggle. But you can see, I'll just give this another 5 seconds to run, and you'll just see that in goes the injection material, and actually that left vocal fold fills up quite nicely, and he gets much better closure. Full disclosure, it then wore off, and he came back for a repeat injection, but he was fine with doing that. So again, just to reiterate, this is my sort of dummy's guide to how I think about managing vocal fold paralysis, and we're going to hear about re-innovation in just a minute. I would just leave you with the thought that paradigms are shifting. The textbooks that were written 20 years ago are now changing. Sitting, watching and waiting for a year is not the way to do this. Injecting early is the way forward. Thank you very much.